Physiowebseries, Shoulder Complex Season 2. Let's begin with Series 2. In Series 2, we will cover remaining rotator cuff muscles including infraspinatus, teres minor and subscapularis. As in Series 1, we discussed about supraspinatus, its origin, insertion, nerve supply, action, along with the associated clinical aspect. The same thing we will do with infraspinatus, teres minor and subscapularis, the remaining 3 rotator cuff muscles in this Series 2. So starting with infraspinatus muscle, it originates from medial 2/3 of infraspinous fossa as can be seen in this diagram. So from medial 2/3 of infraspinous fossa, below this spine of scapula, this muscle originates, goes laterally this way to insert where? To insert on the middle impression of greater tubercle of humerus. So here also we can see starting from infraspinous fossa over here goes to greater tubercle of humerus where it blends with the shoulder joint capsule. This was about the origin and insertion. So the nerve supply of infraspinatus is same as for supraspinatus muscle, which is suprascapular nerve from C5, C6 nerve root from the upper trunk of brachial plexus. So the suprascapular nerve this way crosses here so that it can supply supraspinatus and goes down to supply infraspinatus. So that is about origin, insertion and nerve supply of infraspinatus. Next muscle is teres minor. The action of both infraspinatus and teres minor will be discussed together because they have similar action to perform. So now let's focus on teres minor. So this is going to originate from upper 2/3 of dorsal surface, can be appreciated over here in this diagram, teres minor. So it is the upper 2/3 of, this is the obviously dorsal surface in the posterior view. So upper 2/3 of the dorsal surface of lateral border. So mainly the lateral border of the scapula is covered by this teres minor, and from there it will go to the lowest impression of greater tubercle of humerus to insert there, and also will blend with the shoulder joint capsule over there. In this also we can clearly see from the lateral border of the scapula as two slips it will originate and go to the lowest impression on greater tubercle of humerus to insert. So that is about origin, insertion. Apart from that, the nerve supply for teres minor muscle is axillary nerve from upper trunk and posterior cord of brachial plexus. So we can see here about axillary nerve. So here axillary nerve has been marked, and as it goes here we can see there is superior branch, inferior branch, and from here only we can appreciate this as the nerve to teres minor muscle. So this is the teres minor muscle from the lateral border of scapula to the lowest impression of greater tubercle. So it is supplied by this axillary nerve. Nerve root C5, C6 from upper trunk and posterior cord of brachial plexus. So that's about the origin, insertion of teres minor along with its nerve supply. Now next let's discuss the action of both infraspinatus and teres minor together. So as we know, the infraspinatus starts from the infraspinous fossa, medial 2/3 of the infraspinous fossa of scapula, and goes to insert on the greater tubercle of humerus. And teres minor also we know from the lateral border of scapula it starts and inserts on the lowest impression of greater tubercle. So both these muscles, infraspinatus and teres minor, they work in harmony with each other to externally rotate the humerus, during shoulder abduction movement. So during shoulder abduction, both of these muscles will externally rotate the humerus. That is, they externally rotate the greater tubercle of humerus during shoulder abduction. What is their significance? By doing this, they prevent impingement of shoulder by providing extra space to the subacromial space, to the subacromial bursa. So we know that there is space where there are soft tissues including the bursa, subacromial bursa, and the tendons of muscle of rotator cuff, mainly the supraspinatus tendon. If these structures are getting impinged, it will result into shoulder impingement syndrome, painful arc syndrome. We discuss it that way. So the role of those muscles to externally rotate the shoulder is to prevent this impingement of subacromial bursa as well as supraspinatus tendon, which pass through that space below the acromion process. So we know the action of this muscle is externally rotating the humerus. Infraspinatus as well as teres minor, they work together to externally rotate the humerus. We can on self also try this. If we are internally rotating the humerus and trying to do full range of motion of shoulder abduction, it is difficult to reach that end range. But if we internally rotate and perform shoulder abduction movement, it is quite easier to cover the full range of motion. In internally rotated position, you can feel the restriction at the end range of motion. There is certain jamming like thing, because of which we cannot proceed further to that end range of the shoulder abduction. So it is important for those muscles to stay in tune and perform the external rotation of humerus. As we can see in this picture, there is this resting shoulder where there is, you can see here, subacromial space where subacromial bursa will lie and the supraspinatus tendon or rotator cuff tendons are passing. So there is enough space when the arm is at side over here below the acromion process. But here you can see, as the humerus is elevating, there is this greater tubercle somewhere here. So it will try to hit this portion, and that will result in narrowing space for subacromial bursa as well as supraspinatus tendon. So that means in overhead activities, if we do it without external rotation of humerus, there will be a tendency of greater tubercle and that acromion process to come close together and cause decreased or narrowing of space for subacromial bursa as well as supraspinatus tendon, which is seen in elevated shoulder. So it is clear that external rotation will help to reduce this impingement or jamming of subacromial space. So to prevent this, as we know now, infraspinatus and teres minor externally rotate the humerus, taking that greater tubercle away or rotating it externally, posteriorly and inferiorly, so that there is enough of space even while performing the full shoulder abduction movement. Or there may be pathology where in normal resting shoulder also there is some narrowing of space or jamming occurring at the shoulder joint, where the subacromial bursa as well as the supraspinatus tendon mainly is getting impinged because of pathology, which may be due to incorrect posture or any kind of repeated activities, repeated micro trauma leading to this impingement syndrome. In that also, if the shoulder is elevated, obviously the patient will get symptoms of pain or weakness in that case. But even in normal healthy shoulder, for elevating or doing shoulder abduction activities, overhead activities, we require external rotation of humerus, which is done by those two muscles, infraspinatus and teres minor. Now let's come to the special test. Two tests we will be discussing. One to check teres minor if there is tear of teres minor muscle, and another one to test the infraspinatus muscle if there is weakness or some pathology with infraspinatus muscle. So there is a name Hornblower's test. So this test is performed to test the teres minor. We can see here in this diagram for Hornblower's sign or test. The patient's shoulder is flexed to 90 degrees as well as the elbow is also flexed to 90 degrees. And in this position, the patient is asked to perform external rotation, which is being resisted by the therapist. So shoulder and elbow is flexed to 90 degrees and asked to perform external rotation against the resistance. If the patient is not able to perform external rotation in this position, that means there is something wrong with teres minor muscle. We may conclude to the tear of teres minor muscle. So we can perform Hornblower's sign or test to know about teres minor. And also for infraspinatus muscle, we have to simply resist the external rotation movement. The patient's arm here is at the side of the body, elbow flexed to 90 degrees, and the patient is just asked to resist this external rotation movement. The resistance is applied by therapist and the patient is asked to perform external rotation. If the patient is not able to perform, there is weakness of infraspinatus, then it may be the tear of the muscle. It may be partial tear, full tear, depending on how much the patient can perform. We can conclude that exactly what the pathology is. And if this happens, the teres minor and infraspinatus muscles, which have the important role to play by externally rotating the humerus, then because of that also the patient might get impingement syndromes, because these muscles are not working up to the point to rotate the greater tubercle or the humerus externally while performing shoulder abduction. Now coming to subscapularis. Now we know the role of supraspinatus as we studied in series 1 about it, how it prevents excessive upward translation of the humeral head to balance with the deltoid muscle which primarily works to abduct the shoulder joint. So supraspinatus is also active in the whole range, specifically in the initial range 15 degrees, and also in the rest of the shoulder abduction. So in detail we had a discussion earlier. Now we know about infraspinatus and teres minor as well. Now let's cover up the last one, the subscapularis, which is a multipinnate muscle, can be seen here. So subscapularis can be appreciated well in anterior view. So we can see here it is only originating again from the medial 2/3 of subscapular fossa. So this anteriorly is the subscapular fossa, and from there it goes to insert on the lesser tubercle. All other three rotator cuff muscles, supraspinatus, infraspinatus and teres minor, those three are present at the posterior part of the scapula, and they insert on the greater tubercle of humerus, starting from superior impression to middle to lowest impression. Only subscapularis is the one which is present anteriorly on the scapula, and it will insert on lesser tubercle of the humerus. So here it originates from medial 2/3 of the subscapular fossa, goes to insert on the lesser tubercle of humerus, and the nerve supply for this is upper and lower subscapular nerve. So as the name suggests, subscapular nerve is supplying to subscapularis muscle. C5, C6 again from posterior cord of brachial plexus supplies this muscle. Now action of this muscle is internal rotation. We saw infraspinatus and teres minor, they produce external rotation. Subscapularis will perform internal rotation as well as adduction of shoulder. So this is inner side movement, causing the humerus to be at the side of the body or towards the body, not away from it. So that is the part of subscapularis. So the action is internal rotation as well as adduction of shoulder. Here also we can see how it attaches this way, or here we can see how it attaches, comes from here and attaches this way. So this muscle is helping to perform internal rotation, as this muscle has posterior pull on this humeral head. So here is the insertion and this is the humerus. So it will have the tendency to create internal rotation force because the insertion is here, and when it will cause a pull, so it has this posterior pull because you have the scapula tilted this way. So you can appreciate how it will cause posterior pull on the humeral head. And in this way, obviously, the bone, the humerus entirely will internally rotate and adduct. So it will have posterior pull, that is, the rolling will be anteriorly. The rolling of humerus will be anteriorly and the glide will be posteriorly. So it will roll anteriorly to perform that internal rotation and adduction, and at the same time it will glide posteriorly. We will discuss about this rolling and gliding in detail in the part concave convex rule in upcoming series, further series of Physioweb series. So now we have to understand how this muscle is causing force from here, from its point of insertion, so that it can pull the humerus this way posteriorly. So as the head will roll anteriorly but glide posteriorly and cause internal rotation as well as adduction of shoulder joint. So this was about subscapularis muscle. Now, what will happen if there is inhibition of this subscapularis muscle? There is some pathology, weakness, or inhibition of subscapularis. Now we know that how this will have posterior pull on humerus, on humeral head. So if this is absent, then there will be forced anterior glide or anterior pull on humeral head. So because of this opposite movement, naturally the movement should be posterior pull. So we saw this over here that it should have posterior pull. It naturally has posterior pull on the humeral head. That is, the head glides posteriorly. The humeral head glides posteriorly. And there will be anterior rolling. So we have this internal rotation that way. But if there is inhibition or weakness of subscapularis muscle, there will be forced anterior glide, anterior pull on humeral head, which we don't want, which is not the natural movement. So this will again aggravate the impingement syndrome. The symptoms of impingement will arise, or even we can have bicipital tendinopathy, because all these structures which are passing thereby will have some or the other effect, like they are getting impinged between the bony structures. Those soft tissues, those tendons, those bursa, everything will get impinged between the bony prominences or bones. So this was the part of subscapularis to play, how it causes internal rotation as well as adduction of shoulder joint, that is posterior pull on the subscapularis. And to remember, as we know now, that subscapularis causes the posterior pull on humerus head. Other rotator cuff muscles, they will usually cause anterior pull. So this has to play opposite from that to actually balance. Like during shoulder abduction also, these muscles, rotator cuff muscles, are meant to keep this humeral head in position with glenoid fossa. If it is not able to, then the shoulder will enter into pathology, which we have to deal with. So first we need to understand their basic role, and hence we now come to know how subscapularis, if getting affected, will cause impingement symptoms or bicipital tendinopathy. So if we are finding something like this bicipital tendinopathy, we can think of subscapularis weakness or pathology to subscapularis muscle. So how to test this? So here are the special tests. One is the lift off sign and another is the subscapularis spring back or lag test. So as the role of subscapularis is to internally rotate the shoulder. So initial position is this, and then there is this lift off position. We are asking the patient to move the palm slightly away from the back. Lift off position. So here we can appreciate the dorsal surface of the hand is touching the back, and now we are trying to lift it off, asking the patient to lift it off. And also in the third picture we can see the therapist is resisting the patient's movement. So with this we can test the subscapularis muscle, and also the therapist will watch the scapula or the position of scapula while doing this. If the patient is not able to perform it, that means the strength of the subscapularis is not to point and there is weakness or inhibition of subscapularis, which might be the cause of any other problem faced by the patient. Another one is subscapularis spring back or lag test. So in the start position, as we can see, the therapist is placing it, or the patient is asked to place the palm this way, as we saw in lift off sign. But the patient over here is not able to hold this start position. The palm which was over here, somewhere over here, is trying to move this way, is going to the lower back. So that is the lag. The patient is not able to hold the position over here at this place. It will try to spring back to the lower back. If the test is positive, this will happen. So that was about lift off sign and spring back or lag test for subscapularis, with which we can test the muscle. So this was it about the rotator cuff muscles. The remaining three muscles, infraspinatus, teres minor and subscapularis, along with their clinical aspect, are discussed in this session number 2 or series 2.